Hey everyone, welcome to part 3 of our EOE webinar series. This webinar today is going to address folks that may have had an eosinophilic esophagitis or EOE diagnosis maybe a few years ago, maybe recently, and they're not doing anything about it. They're still struggling with symptoms, or maybe a loved one or one of their children is dealing with this. And we're here today with two amazing experts from the Cleveland Clinic, Dr. Sophia Patel and Dr. Scott Gabbard. They're amazing gastroenterologists. Dr. Patel is a pediatric gastroenterologist with the Cleveland Clinic, and she's co-director of the Eosinophilic Disorder Center at the Cleveland Clinic. And we also have Dr. Gabbard, who is the section head of neurogastromotility at the Cleveland Clinic. So we have two heavy hitters today. They're going to explain everything you need to know about why you should seek treatment and get care if you've been diagnosed with EOE and haven't done anything about it. So I'll let them take it away.
Thank you so much. I think this is something that we see that at least in my 14 years of gastroenterology practice, I've seen throughout my 14 years. But in 2023, I've really seen it over the past 2 or 3 years, in part because of the COVID pandemic, where people have been putting off their medical care and not getting the care they need for their eosinophilic esophagitis and showing up with more severe disease. And so, part of this, what I want to get through to people is why it's so important to follow with your care provider and make sure all aspects of your eosinophilic esophagitis is treated. So I'm going to start and talk about the adult perspective, and then Sophia will discuss the pediatric perspective, and there's some similarities and differences. On the adult side, men are really stubborn. And I see this all too often in my male patients as they get older. They tend to let this go. And we of course, we do have some females who let this go. But boy, we see a lot of men who, will work really hard, get their disease under control. And then over the span of a few years, some of their medicines drop. They don't follow up. They don't refill their medicines. They're not talking to their provider, and all of the sudden their esophagus has become so narrow that they're struggling with every meal. And their significant other brings them in to my office and says, he struggles with every meal. It takes him 45 minutes to eat dinner. Everyone else is done in 15 minutes. He has to chew everything. And the guy will just hang his head and, yeah. But this is something that we are seeing. And I want, Dr. Patel and I just want to let you know, this is a really treatable condition. And boy, we make quality of life so much better for individuals. And of course, the thing that we worry the most about in eosinophilic esophagitis are sort of the acute emergency episodes where something gets stuck in the esophagus, and that's called a food impaction. And often if that, doesn't relieve, pretty quickly, patients end up having to go to the ER to get a piece of food removed from the esophagus. And I'll have patients who say, yeah, it'll feel stuck for 5 minutes and I can work it out. Or, hey, I waited 6 hours. And of course, that's too long. Don't wait that long. And it finally worked itself out. But in general, if something's getting stuck and it's not getting out of there, within a few minutes, you want to start thinking about going to the emergency room, because you may need the food removed. And one note on food impactions that I've always found really interesting, and of course I love saying this, is that the esophagus is really stupid. Not just, people with EOE, but in general. We'll get called in the middle of the night, and at least on the adult side, it'll be a piece of chicken or a piece of steak or a piece of pork. And the patient will say, I feel it stuck here. And we go down with the scope and it's actually down at the bottom of the esophagus. It's because the nerve runs up and down. People feel like it's stuck up here when it could be stuck anywhere in the chest. And Sophia, just talk about, food impactions in kids. Do they present similarly, or is it more of a challenge for kids?
So for kids, it's really interesting because EOE is more of a spectrum of a disease. So we see a variety of different symptoms depending on ages. So younger kids like toddlers and infants can have EOE, but often they present with very nonspecific symptoms. So picky eating, which what toddler isn't a picky eater, vomiting, reflux type symptoms, and lack of weight gain. Those are the kind of top symptoms that we see in that age group. As they get older, though, they do develop more symptoms very similar to adults. And a lot of times because they've had so much time to live with the disease that they've sort of become more accommodative of what they can eat, what they can't eat. They become very picky eaters at older ages, which for kids is pretty unusual. Most kids grow out of picky eating by the time they're 4, 5, 6 years old, but we have 9-year-olds who are avoiding, mom's baked chicken, or they're going to a restaurant and not eating a hamburger because they don't want to have an issue. So that is definitely a difference in between the adult and pediatric population, but certainly the time that we end up seeing the patients when they're older and they've had the disease for longer and it's been untreated, they definitely have more symptoms similar to adult patients as well. So it's the typical teenager, mom took him to a steakhouse for his birthday dinner. He was eating at the steakhouse. He started choking on the steak. It was a big problem. Most of those kids, and it's always, a lot of times it's the he's, but it's also in females too. But then they, become very embarrassed. They don't like to go out to restaurants with their friends. This becomes a big social issue as well. They're, at track dinners and they're the last ones eating. That becomes, in their families, it's one thing because they're just used to it. So if you ask their parents like, oh, so who gets done with dinner first? And they're like, oh, definitely not my kid, he's always there late, or he's taking forever. He's drinking a bunch of bites in between foods. So that definitely is, as they get older, because they've learned for so long, just like in adults, just to accommodate their foods, take forever, avoid certain things. They can get the narrowing and the strictures, the fibrosis, scar tissue. So they definitely have those symptoms as they get older, but the younger kids are definitely a little bit more trickier to diagnose because they do things that all toddlers do, but into amounts that, kind of start affecting their weight and their growth. So
this is an interesting point of discussion. And I want to go back to, why are people maybe stopping treatment? And you kind of alluded to the pandemic and, they've already been diagnosed and maybe the parent is seeing some of the adaptive behaviors that you both have described, whether it's drinking lots of water. So obviously the symptoms are still going on for these patients. Why would they have stopped treatment? And how can we, address that?
Yeah, so I think it's in part what Dr. Patel said, is that this is a slowly progressive disease. And there are two components in eosinophilic esophagitis. There's inflammation, and then there's scarring, what we call stenotic or fibrotic disease. So inflammation over time progresses to scar, and scar in the esophagus makes the esophagus really narrow. And it's a slow progression. And so, what we'll find is, for example, I'll have patients who, will come in with a very narrowed esophagus, and I'll spend months stretching them out progressively, getting their esophagus wide again, getting the inflammation under control. And they'll go a year or two, everything's good. And then they'll just decide they want to stop their medicine. And it's a slowly progressive disease where, like Dr. Patel said, it's not something where, hey, on, Monday, I stop my medicine. By Wednesday, I'm having symptoms. It's a slow progression over months or years. People accommodate and they forget what normal is. And, again, part of seeing a gastroenterologist is, in a gastroenterologist, we're treating both the inflammation and the scarring, and we get a lot of help from, and we'll talk about this from, our allergy colleagues, our dietary colleagues. But again, they treat mainly the inflammatory component. The narrowing often will require endoscopic stretching or what we call dilation. So you have to treat both to get a great response. But in answer to your question, why do people fall out of treatment? Because it's not a sudden change. It's progressive, and people are stubborn. People are stubborn, and I get it. They don't want to come to the doctor, but hey, now we have virtual visits. I mean, it's a lot easier to get the right care from a gastroenterologist.
And that leads me to my next question for your discussion is, can you explain, for all those who may be teetering on, oh yeah, Dr. Gabbett and Dr. Patel are telling me the right thing, and I know they're talking about me. what is the importance of medical care and guidance? And you kind of alluded to this earlier about, how the progression over time, but I think we really need to hammer this home. It's an important point.
Mm-hmm. I think that's a really great point too, that Scott made as well. A lot of times in our populations, sometimes the kids are too busy, the parents are too busy with work, it's hard to get out, and the virtual visit is such a great option to bring them in. We also, we see a lot of parents who are like, well, we won't bring him in because, we're on vacation, he has sports, I don't want him to miss anything with all these procedures. And this disease does require procedures to evaluate and diagnose and treat over a long period of time. And that makes people worried. It scares them. They don't want to hear some of these things that we're telling them. And that's completely understandable. But that's part of, why it's important to find a good team approach to getting the treatment for EOE, because, we're not trying to make their lives harder. We do want them to feel better. And this can improve your quality of life in so many ways. And then to answer your question, so the importance of medical care is it's definitely in different age groups where we see patients, it varies. So in toddlers, after a certain period of time in infants, when you're not eating, you're having issues with acid reflux or vomiting that can accompany the EOE, those kids become very picky eaters. Meal times are just a struggle. A lot of times we have to have patients see therapists, feeding therapies, feeding teams to help with just like the chronic issues that they've been having. That's probably stemmed from a lot of their eosinophilic esophagitis symptoms. And then that leads to like more chronic changes, so weight loss. And then, of course, we don't want them to lose weight. We want them to be gaining, and their developmental outcomes can certainly change if they're not getting enough calories for their brain to grow. And that is definitely something that we are concerned about in that age group. And then older kids, like we said, and adults, very similarly, they'll see more often that they'll have food sticking, trouble swallowing, social situations become very difficult, going to restaurants with your friends, or going for a sleepover. Like, what if that mom makes, chicken sandwiches? Well, we're done for, can't go to that sleepover. And obviously, like in the long run, we'd like to avoid seeing you in the middle of the night because you had a sub and it got stuck. And then you had to go to the ER, and, that's even more, that emergency situation is really what we want to try to avoid, especially in teenagers and older patients. And then the choking episodes, and that leads to more fear, anxiety, and kind of restrictive eating behaviors in older patients as well.
And, to Dr. Patel's point, I'll give you some anecdotal experience. Yesterday was my endoscopy day. And so I think scoped like 14 people and stretched quite a few of them. A few of them have eosinophilic esophagitis. And I told our entire nursing staff yesterday, eosinophilic esophagitis, caring for this is one of the most rewarding conditions, because patients come back to me. Patients will start, normally the esophagus is 20 millimeters in diameter, and we'll see patients we can't put our regular scope through, which is 9 millimeters. We'll have to switch to a pediatric scope, that's teeny tiny, like 4 or 5 millimeters, just to get the scope down. And we'll sequentially stretch these patients, and they come back. And my nursing staff will hear this every day. I'm in scoping. They say, I can't believe how much better my life is. You have no idea how much you've changed my life. Now I can eat. I had no idea how bad I had it. And patients will come to me, their esophagus is only 12 millimeters, and they'll say, I'm barely having any symptoms. Doc, I feel great. I said, tell me that in 3 months when I've made your esophagus 18. And sequentially, we'll get them up to 18 or 20. They'll come back and said, I had no idea what normal was. No, I was still having problems. I just didn't know what normal could be. So it is very important to see someone who, will think about all the aspects of eosinophilic esophagitis, not only the inflammatory component, but the narrowing as well, to really get this. And I know Dr. Patel, I'm sure the same way with these patients who start very, very narrow, and they come back once they're normal, and it's just incredibly rewarding on our end.
It is. It's kind of like, I think surgeons really like their job because they fix people like that. And that's kind of how this feels. You see them after the first visit, and even the patients who initially came in and, we have a lot of teenagers who are kind of in denial and they don't think anything's wrong with them. And then even they are telling you, hey, I feel better. I'm actually like eating, at the same time as my football team. I'm finishing on time. I'm not the last one sitting there. And I don't think they realize how much better their life can be. And because they've been so used to a certain feeling for so long. So
this is so great and so positive. And this is the whole purpose of this webinar series, is to really encourage people to get back into treatment. And I'm so curious, when you say you made the esophagus larger, what are the treatment options and what's new and what's out there for patients that they need to know about, and why they should really, go back into treatment and see their gastroenterologist?
Yeah. So, it's becoming a very exciting time for eosinophilic esophagitis treatment. For many years, in the vast majority of my career, we've not had an FDA approved medication to treat eosinophilic esophagitis. We've done off-label therapies with proton pump inhibitors or topical steroids. I tell patients, not bodybuilder steroids, but anti-inflammatory steroids to cool down the allergic inflammation, right? Eosinophilic esophagitis is an allergic condition. And all of these therapies, either proton pump inhibitors, swallowed steroids, or dietary change, all have been used, again, the proton pump inhibitors and topical steroids off-label, to decrease the allergic inflammation in the esophagus. And they've been, pretty good. They do a pretty good job for quite a few patients, but there have been subsets of patients who either haven't been able to tolerate the diet or the medical therapy, or the medical therapy hasn't fully helped them. And so, our exciting news in the eosinophilic esophagitis world is we do have a FDA approved therapy for those patients now. Dr. Patel can talk a little bit about her experience with that.
Yeah, absolutely. Eosinophilic esophagitis being an allergic disease, fortunately, because of the former allergy research, we have a lot of medications available. Some of them are still in the pipeline, but the newest one that was approved is dupilumab. And that was approved last May for patients over the age of 12 for eosinophilic esophagitis. And specifically, it's not just for patients who are refractory, so who are not responding to therapy, which is a really nice option for patients who have issues also with complying with certain things. Taking a medication twice a day can be difficult. Following a diet for a long period of time can be difficult too. And fortunately, this medication has been around for a while, almost 10 years. It's been initially studied in asthma. And I often equate to my patients that eosinophilic esophagitis is kind of like asthma in your esophagus. And this medicine, it's been used for asthma for 10 years. It's approved as young as age 6 months for eczema, atopic dermatitis, which oftentimes we see patients with eosinophilic esophagitis struggling with other allergic diseases where they've seen an allergist for many years. They have uncontrolled eczema, or they have like allergic rhinitis. They're taking Flonase every day, the nasal fluticasone. So fortunately, this medication, not only in the trials had showed significant improvement in patients with eosinophilic esophagitis, it also helps treat some of their other allergic diseases. So we do get kind of a whole symptomatic improvement just in terms of like the other allergic atopic diseases they might have, including asthma. And fortunately, it's a very safe medication. It's not, the administration is not the most ideal. It is an injection, which a lot of my pediatric patients are, obviously they've been having immunizations for years and they just don't like that kind of thing. But if you can, when we talk about shared decision-making and, meeting with our multidisciplinary clinic, we try to present to them all the options, not that that's the only one, but dupilumab is really going to change the face of how we treat eosinophilic esophagitis, and especially in the patients who have already had scar tissue or the narrowing. It certainly helps that population significantly as well.
So when you say you increase the size of the esophagus to get it back to normal, is that because you're reducing the inflammation, and that way it kind of settles down and gets back to a normal size?
Yeah. So when we see patients and we dilate them, at that point, really the dilation is kind of the thing that's going to help them the most. because if our scope can't get through, you can't imagine our scope is, like I said, about 8 to 10 millimeters, about this size of a hole. And if you're eating food and it's bigger than that, it's going to get stuck. So for immediate relief, a dilation is a very safe and effective option. It's not something that we like to do all the time. And we do have to do what we call, that Dr. Gabbard earlier alluded to this, as serial dilations, where you can't just bang it open the first time. You have to do it a little bit at a time. Otherwise, the esophagus will, it won't let you do that, essentially. So what ends up happening there is we do the dilations, and fortunately with the treatment for EOE, especially with the dupilumab and these newer therapies, and even just our general therapies, they do decrease that inflammation and decrease the chance that you have to develop those narrowing or the strictures as well.
Yeah, I mean, Dr. Patel sort of gave a good overview of dilation, but during a scope, we essentially stretch the esophagus, and there's two major ways we can do that. One is with a balloon that we fit through the scope that opens, and then the other type, and the type that I favor, is using a long stretching tube called a bougie dilator, and we can thread it over a wire, and it goes all the way down. It's sort of like I tell my patients it's like swallowing a sword, except it's a long polyvinyl tube that's tapered and smooth, not a, and it's guided with a wire. We do it during endoscopy. It's a great procedure. We do it under sedation. When I started, 14 years ago, there was still some concerns regarding risk of tearing in patients with eosinophilic esophagitis. And boy, the older docs, you can't be too aggressive. You can't dilate, risk of tear. A lot of studies over the past 14 years have shown if you are careful stretching the esophagus, the risk of tearing the esophagus isn't any greater for patients with eosinophilic esophagitis versus other conditions. It is very safe as long as, again, you're doing this with someone who has a expertise. And again, I'm biased. I like to think that in gastroenterology, we get amazing training during our fellowships in eosinophilic esophagitis. And so I would, urge all of our patients that if you are getting scoped and you're getting treated, make sure it's with a gastroenterologist who's gone through training. There are other types of doctors who do endoscopies, but part of their training does not include eosinophilic esophagitis. So just an urge to patients, there's a lot of good other specialties that do endoscopies, but not for this condition. Make sure it's with a gastroenterologist.
No, this is really important. And that leads us to our next question is, how can a patient get back on track now that they've listened to what you and Dr. Patel shared? And I know if I was a patient, I feel encouraged to get back into treatment because I don't feel as fearful, and I feel like I don't want my esophagus to close anymore. So I really need to get back into treatment. What are the next steps? I don't want to feel embarrassed in telling my doctor, I'm so sorry I haven't gone to you, but they're not judging us, right? The doctors aren't judging us. Can you give us some tips and how we could get back into treatment and get back on track without feeling?
We completely understand, because doctors are the worst patients. So don't feel bad going to your doctor and saying, I haven't been taking care of myself, because your doctor's probably a worse patient than you, in all honesty.
I can wholeheartedly agree with that.
So we don't judge. We love this condition. We love making patients better. So we love seeing this condition. It's a great condition. Not a great condition to have, but if you're going to have something, it responds way better than most other things we treat. So we love taking care of patients with this. So please let us know. Come prepared when you talk to your doctor. What foods get stuck? How long do they get stuck? Where do you feel them get stuck? What circumstances? Because we want to know all of that. Don't try to hide that from your doctor, because we can make you better. This disease responds very well to treatment. So I would say, make sure to describe everything to your doctor. When looking for a doctor, for this condition, there are a lot of great resources out there in the adult world. I would, you can use the American College of Gastroenterology or Gastro Girls website to find a provider. But then I would go a step further, and it should be in there, but always check to make sure that your provider who's taking care of this If it's an adult gastroenterologist, make sure that they are board certified. And that's the American Board of Internal Medicine, so abim.org. Make sure that you check your doctor, make sure that their board certification, his or hers, is up to date, because this disease has changed over the past 10 years. There are some gastroenterologists whose board certification lapsed. They may not be updating. So make sure you're getting someone who's up to date with all the newest therapies. But at least in the adult world, really make sure it's a gastroenterologist. If you have really severe disease, try to find a specialist, an esophageal specialist. We call them esophagologists. He or she will often have connections with allergists, with dietitians, who specialize in this condition and who can help beyond the standard therapies.
And you bring up a good point. You started to name some of the multidisciplinary care team members. What's the importance of working with, say, a dietitian or an allergist, and how does it all fit together with a gastroenterologist?
That's a great question too. From a pediatric perspective, I agree with everything that Dr. Gabbard said. The AVP is our certifying board, so you can always check there. The best route to a gastroenterologist in the pediatric subspecialty would be through your pediatrician or your family medicine doctor that you're already seeing with your child. I will say that our family medicine specialists are so great at figuring out whether this is something that needs to be referred, because they see it in all ages. And our pediatric colleagues are also they're just wonderful at picking up whether this is like a normal vomiting kid, or if this is something that's happening a little bit more than it should be. And definitely, finding someone who's board certified is very important. But to your point, what we do in our clinics, in this multidisciplinary care clinic, it's not available everywhere. In Ohio, we're lucky to have a lot of great pediatric hospitals. In Northeast Ohio, we only have a few of these models available, and it's generally run and successful because you're able to come in and see everybody you need to see in one visit. So it is a long visit, so I will warn you that you'll probably be there for a little while. So plan on at least 2 hours to come and hang out with us. But it's nice because you get to talk with a gastroenterologist and an allergist as well. And you can talk about, if your child has food allergies, which often patients do when they come to see us anyway, or if they're getting therapies for, a peanut allergy or something like that. A lot of times they'll come to see us after they've developed EOE later. And then you're able to see both of us. We're able to address kind of a lot of questions that you may have in 2 separate visits in one visit alone. And then we also have our dietitian come and talk with you about other options that, if you think that it might be something that's worth it to do a milk elimination, she can kind of describe to you what that looks like without, we don't want to force anyone to do anything. We want to fit something that's best for your lifestyle, that's going to work for you. So if you don't think your kid is going to stop eating pizza 3 times a day, I'm not going to tell you to stop doing that. I think that's unrealistic. I'm going to tell you that there are options, but fortunately, we're lucky to have so many different treatment options now. And our allergists have had a lot more experience as well with this new medication with dupilumab than we have. And they're able to add a little bit more of like the more detailed trial data and things like that as well. So, and I think having like multiple experts, you kind of get different perspectives from different people. And fortunately, we're all kind of on the same page, which is great. Your gastroenterologist will definitely be the one doing your procedures, your scopes. We have a lot of non-invasive procedures that are available now, including a nasal endoscopy that we're doing at Cleveland Clinic Children's. A lot of my patients they get a little bit nervous about it, but I promise it's not that bad. We try to make you as comfortable as possible. And we use like 3D goggles to distract you a little bit during it. And we also have a cute dog that can come in during your visit. Even during an EOE clinic, if you want to meet our celebrity dog, you can meet him. We'll bring him in. So he's part of our multidisciplinary clinic. It's very important. Great. He's a very important member. So
sure.
And I know we didn't touch on it too much, and I know this is a very challenging part, is the dietary and the elimination diet, and that's a whole other area, and I think we're going to touch on that in other segments of our webinar series. But just briefly, as an option, so patients are aware, what is the elimination diet, and what does that require in terms of consistent upper endoscopies and biopsies to see how that's affecting the lining of the esophagus.
Yeah, I think, the dietary elimination is what I would consider as like curative for eosinophilic esophagitis. And that's because we know that there are foods that trigger those allergy cells to get into that area and cause the inflammation. And generally the top 3 foods, and this is a little bit different in adults, but milk, wheat, and eggs. And then soy is another one that is very common in adults to cause those cells to get there. But the milk is probably the biggest offender. And there have been a lot of more recent data studies in the last, even the last 6 months that show that just doing an elimination diet of one food, instead of trying to make people eliminate 4, 6, 7 foods, just eliminating one food, which most of the time is milk products or dairy, that includes yogurt, cheese, those kind of things, is enough in almost like in our pediatric population, and up to 60% of patients respond to just removing milk alone. It is a little bit more intensive in figuring out whether that is working, because you do have to do a repeat endoscopy to evaluate the tissue. And that's the only way that you can tell whether any of these therapies are working, is by repeating the endoscopy, which is hard to do in kids. I don't love to, do this over and over again. It's something I think in pediatric gastroenterology, we're kind of like, okay, you look great, let's continue on. But we know through a lot of studies and data that the tissue disease in the esophagus often doesn't reflect how the patients are feeling. Sometimes they feel great, and then we go in and it looks awful. So that means that that inflammation is still there. The chance of developing that scar tissue is still there. So a lot of these therapies, most of them, you do have to repeat the scopes. And usually what happens is if we find the food that works, then that's kind of your food that you're not eating for a long period of time, and possibly, over your whole lifetime, just because EOE is a kind of a relapsing, remitting disease. It never actually goes away. And then if you stop therapy, your symptoms will come back. So
can patients have the option to do a combination? Maybe some of the pharmaceutical products help, or with eliminating one food, especially in pediatrics. So there are options, correct, for patients?
Absolutely. Absolutely. Yeah. We generally try to pick one thing, because I think when you start doing multiple things, it kind of becomes a little bit more limiting on their life. Like taking a medicine and then also removing dairy. So we try to figure out whether one thing is going to work versus the other. So we try to kind of stay in one lane if we can.
That's good to know. Now, I know we're going to wind up this segment. I always like to highlight the positive, and just in your experience, to give examples of patient success stories that maybe there was someone that removed themselves from treatment for a while and came back, and how was that, how did that play out for you in your practice?
Yeah. I mean, we all have so many success stories. I think one with amazing pictures that he's given me permission to share with people. I call him my P man, and PEA. So he's a gentleman who first presented with a green pea stuck in his esophagus. So that's how narrow his esophagus was, and had it removed in the emergency room, not by me, by my colleagues, and removed. And then you can see afterwards just how narrow his esophagus was. Not only could we not fit the regular scope through, he was close to not being able to fit the pediatric scope through his esophagus. And he's in his 70s. He's a stubborn guy, like nice as can be, but just doesn't like coming to the doctor, and had accommodated over 20 years to the point where he couldn't get a green pea unless he chewed it.
Wow.
So, we individualized his care. We got him on, medication, controlled the inflammation. It took a few sessions to stretch his esophagus out. We put the stretching tube down, the bougie dilator, and it does open up the lining, not all the way. So it opens up the lining, not all the way. And every time we stretched him a little bit more, and within 6 months, his esophagus now is 18 millimeters. And every time I see him now I scope him like once a year to keep things open. And he's eating steak. He said, yeah, I went to a barbecue. I had steak, no problem. Like, you've changed my life.
Oh,
and so I'm seeing him every year just to remind him, like, don't get back to where you were, stay on your medicine. But I mean, my goodness, to go from not being able to fit a pee down to like having no trouble swallowing, no trouble. I mean, and so this is what we can provide when you treat both the inflammation and the narrowing. And I know Dr. Patel has another amazing story with pictures that I was looking at your slides, and
Yeah,
I was kind
impressive.
of amazed at this. So I wanted to hear your story on the pictures you had.
Yeah. This is a really interesting patient who we knew had eosinophilic esophagitis many years ago, but again, decided for whatever reason, at the time he was 12, kind of didn't return for follow-up. And then he came back to see us, and he was just telling us that, I have celiac disease, because he also has diabetes. So we did some labs, and then he mentioned that he was still having issues with swallowing. And I recommended that he have a scope done, because he's been, he was saying that he felt fine. And when we did his scope was so narrowed that we couldn't pass that smaller than neonatal scope. And we actually had to go and we tried to dilate, but because there was so much narrowing, that our dilator was not long enough to dilate his entire esophagus. So we were able to dilate a small part. This patient is the perfect candidate for one of those new medications, which is the dupilumab. He was started on that. And after 3 months, we repeated his scope, and his scope almost looked like a normal esophagus. Just the amount of the difference it was just very impressive. And he feels great. So, and he used to not talk to me during the visits because he didn't want to know what was going on in his esophagus. And now we're friends. So it's great. It's very rewarding.
So it's why we all do what we do, right? Especially the medical professionals. And I feel honored to be able to share this with our audience in hopes that someone, if it is just one person, gets back on track and goes to their doctor, makes that phone call, they could, end up feeling so much better, hopefully, with the right treatment and under the right care.